So my question is, should we put more focus on integrating breathing training into OMT? What's the rationale for this and what's the evidence? And my impression is that breathing training can actually be used to improve nasal, upper airway, and tongue function. The evidence is there that we can start paying attention to breathing a bit more because it'll contribute and add to the results from myofunctional therapy. So, when you think of the nose isn't just something sitting in the middle of your face that conducts the air. The nose is actually part of a unified breathing system. It's really interconnected with the lungs, but it's also integrated with the breathing control system in all kinds of interesting ways in the brain. We can start to think a bit more kind of neurologically, about the nose and how it functions and how it interacts with the neural inputs into breathing. And also thinking about the tongue and upper airway dilating muscles, it's important to realize that they're neurologically and functionally connected to the breathing system, and they're under the control of respiratory related brainstem neurons. So in a lecture earlier, a week or so ago, somebody commented that, the tongue is a respiratory organ. And it's sort of interesting way of saying that, but certainly there's a huge integration. What I'm suggesting is that, that we need to think about functional nasal rehabilitation. And a functional nasal rehabilitation would be something that really rehabilitates all the nasal functions and thinks about the nose in the context of the whole breathing system. So in the literature, there's stuff there already, but not a lot. So Luca Levrini, who wasn't able to make it to this panel, although I did invite him, did a wonderful paper on oronasal rehabilitation, which I think is really, really worth reading if you're interested in this area, where he did a very comprehensive sort of nasal breathing training that included working with the muscle and sensory functions of the nose as well. And in the literature, there's been other work too, using biofeedback to improve nasal muscle function. And then there have been some interesting studies on functional breathing retraining for, breathing pattern disorders and hyperventilation. And there's a New Zealand ENT called Jim Bartley who did a wonderful study with patients who had had up to 4 different sorts of nasal surgery and had had medication for their, nasal obstruction issues for many years, not responded. And he measured their breathing and found that they had breathing pattern disorders, lots of breathing symptoms, and a couple of them actually had hyperventilation. And he found that retraining their whole breathing system was able to help them to restore their nasal breathing. People have also worked on olfaction training, the sense of smell. The sense of smell is very important neurologically. The nose connects with the brain, with the olfactory bulb, and then the rest of the brain. And so, we could start thinking about nasal breathing retraining that incorporates that function. And then, of course, there are techniques like humming, different sorts of humming that people have shown to be helpful for people with chronic rhinosinusitis. So a functional approach to nasal rehabilitation could also consider things like how the nose interacts with the brain to help brain lateralization, which helps settle the nervous system, and how it can help to improve nasal limbic connections. So I'm just going to skip that slide. So breathing is multidimensional. In my PhD research, this was the main finding, that dysfunctional breathing is really 3 components. It's got biochemical, biomechanical, and structural, and then also psychophysiological to do with the brain and nervous system. So I think that we need to look more carefully at breathing and looking at sleep apnea. It's been known for a long time, the research has been out there for a long time, that function matters in all types of sleep apnea. So whether it's central, obstructive, or mixed sleep apnea, the anatomical and structural interact with the functional and physiological. So I did a review last year of breathing retraining in sleep apnea, just looking at the different approaches and potential mechanisms. And, there are all kinds of things out there like singing and didgeridoo playing and double reed wind instruments and, inspiratory resistance muscle training, building up the strength of muscle. There's been diaphragmatic breathing training and a case study on Buteyko. So it's like there's still not enough evidence. We really need to do the research. And in all these papers, all they did was propose mechanisms rather than actually proving any mechanisms. So there's a bunch of hypotheses out there. And, you know, breathing retraining, really the time to explore this in sleep apnea, because, you know, all the wonderful research that's been happening with Danny Eckhart, who's here in Australia, and other people looking at the, you know, functional phenotypes of sleep apnea. And, you know, showing that in a small group of people, 20%, well, it's not that small, they only have a minor anatomical deficiency, but 100% of them have some functional impairment to do with non-anatomical traits. So dysfunctional breathing can contribute potentially to all of those functional traits that contribute to sleep apnea. It can contribute to respiratory instability or loop gain. It can contribute to upper airway muscle dysfunction and also to low arousal threshold. So, you know, the sort of treatments that are put forward for this functional phenotype targeting approach, you know, include things like, you know, giving supplementary oxygen or giving certain types of medication for unstable ventilatory control. But breathing retraining works for that, because unstable ventilatory control is like one of the hallmarks of dysfunctional breathing. People don't regulate their breathing well. Low arousal threshold, you know, it proposed to be treated with sedatives and non-myorelaxant hypnotics, but breathing retraining can do that. Airway muscle function, you know, people are starting to use hypoglossal nerve stimulation, or they're using certain types of chemical stimulation or orofacial myofunctional training. But what I wanted to say is that breathing training can also really impact on upper airway muscle function, because, you know, the upper airway, like the nose, is connected to the whole breathing system. So beyond dysfunctional breathing, breathing training also has potential effects on upper airway function that's independent of dysfunctional breathing. So this is a dense and complex slide, and probably not for this stage of our discussion, but perhaps we can talk about this. And this is my kill everybody slide, trying to figure out what could be the mechanisms. So I just put this up here, not because we're going to, you know, talk about this, but just to say, look, we've got to do the research. There are a lot of potential ways that breathing retraining can really, really be helping sleep or myofunctional therapy, but the research is still really lacking, and clear clinical protocols that are evidence-based are lacking as well. So how did I do on time?
Great. You did great. Fantastic. Yeah, perfect.
Okay. So anyway, that's just to open up the discussion, really. So is there someone who would like to come forward first?
I don't mind coming forward. What I would like to address is different, very, very different from what we just heard, where there is less apparent interest in the physical structure, where I am going to stress the physical structure. So what I'm going to show you, for example, I want to show you this slide. This is a diagram portraying the classic typical OSA male patient. And what we're looking at is physical structure. Number one, if we look at the profile, we're going to see a retruded mandible. Okay? Number two, as the mandible retrudes, we're going to see the tongue in the airway. As the tongue goes in the airway, by the way, the head comes forward. That affects cervical spine posture. Let me demonstrate. This is the tongue that we have. We're the only mammal with a tongue like this. This is our nose, posterior nasal pharynx. If the tongue goes into the airway, the head comes forward to breathe better. And when that happens, we can reverse the natural curvature in the spine. So the physical properties of this obstructive sleep apnea patient is a kyphosis in the cervical spine and a retruded mandible. These are very, very significant characteristics. And I'm going to tell you, the importance of myofunctional therapy is absolutely enormous And let me show you where. So what I'm presenting to you is the concept of looking at head position and head posture. If we don't consider head posture and breathing, we're not looking at the whole story. Very simple. And here's how it works, particularly today, with everybody on their computer, their tablet, their cell phone, their head is forward. The literature says all you need is to have your head forward 2 hours a day, and it'll affect your cervical spine. Now, let me explain the whole myofunctional concept. When your head is forward, the two muscles that support your head are the upper trapezius and the SEM. This is 12 pounds, maybe even 14 pounds. When your head is forward, something has to support it. That's your upper trapezius and your SEM. Now, why is that significant? Every muscle in our body has antagonists. What is the antagonist to the upper trapezius, which is now tense, holding your head? The antagonist muscles are the suprahyoid muscles. What is the most important muscle in the entire body for maintaining the oropharynx? The geniohyoid. So with a head forward posture, you're losing the tone of the muscle that goes from the hyoid to inside the mandible. That's dropping the hyoid. And guess what? A low hyoid is a biomarker for sleep apnea. So how do we fix this? We need to tone those muscles. That's where you guys come in. I developed an appliance that works perfectly effectively with the myofunctional therapist. What do those muscles do? That when you swallow, they lift the back of the tongue. How do you tone those muscles? Well, if you put a simple little appliance in on the lower with a unilateral bite block, which is what I'm all about, unilateral bite block technology, what happens is the base of the tongue, when you swallow, has to travel twice as far. That's how you tone those muscles. So if you're taking a patient and using myofunctional therapy to train that patient to keep their tongue up against their palate, now they have to work twice as hard to get their tongue up against the palate because the tongue has to travel twice as far. So I am clearly saying that we can work through musculature to open the airway. Now, what is the second most important muscle for maintaining the oropharyngeal airway? It's the largest muscle that maintains the oropharyngeal airway. That's the genioglossus muscle. That's your base of the tongue. That muscle is designed to stick your tongue out forward. And what happens when you clench? You contract the genioglossus muscle to open the airway, because as it contracts, it comes forward away from the posterior airway wall. So when you have a unilateral bite block appliance, when you're clenching on it, you're toning the base of the tongue.
Well, Dr. Belfour, I appreciate how you're bringing in this interconnected muscle breathing skeletal relationship. And it's absolutely true. This is myofunctional sciences. The stomatognathic system is what we're looking at from many different angles. The ability to hold the head and neck posture and this breathing influenced form that takes over. These are all aspects of our breathing discussion. I wanted to pass the baton back to Rosalba, because I know we have some other panelists coming in, but you bring in a lot of the muscular relationship of breathing.
Yes, thank you. It's true. The muscles are really important. The nerve supply to those muscles is linked with breathing. So it's the function still matters. So I think anatomy is focused on much, much more than function, and function is generally ignored. But, you know, it's great to be reminded of that. And it's super, super important. It's like everything happens on the basis of the structure, for sure. So
one thing, please.
Sure.
I want to stress this. If you read the white paper, the American Association for Orthodontists white paper on the etiology of sleep apnea, They state it's the collapsibility of the airway. So why aren't we looking at the muscle toning to prevent the collapsibility of the airway? That's all I'm saying.
Oh,
That is
yes.
the key to the entire program, the key.
Yeah.
And I basically say that with that, you can improve every single patient, every single one of us,
Yeah.
by toning our airway.
Yeah.
Mhm.
Yeah, that's right. No one would argue with that. Maria, can we have yours, please?
Yeah, I'm just going to introduce her a little bit. I'm going to be helping
Yeah.
translate for her.
Thank you, Ted.
Thank you, Ted, Dr. Belfer. Maria and I met at meetings in Peru and at Colombia that AMS was involved with organizing over the last several years. And I was so excited to meet her because she was working on a doctorate on myofunctional therapy and breathing reeducation, craniofacial morphology, and posture. And so I was like, wow, this is the kind of thing that we need. And so muchísimas gracias para su presentación y se puede hablar en español sin problemas.
Muchas gracias, Mark. Quiero enviarles un gran abrazo desde Chile. Tú me ayudas a traducir, ¿no?
A great big hug from Chile.
Quiero decirles que estoy muy emocionada de ver cómo en distintos centros del mundo estamos pensando de la misma manera y estamos viendo cómo las ciencias miofuncionales necesitan de estudio y necesitan de mayor visualización, porque tal como hemos visto en los experimentos que yo mostraba, estamos realizando en nuestro centro y tal como decía el doctor Theodor recién, hay una serie de cambios anatómicos y también a nivel microestructural que están ocurriendo en la musculatura miofuncional.
Okay. Mark?
She says that she's really excited to know that all over the world, there are the same kind of questions around human anatomy and physiology. And that we really need to advance science around each one of these topics. And it's great to see, you know, these kind of questions coming up in specialties like dentistry as it relates to myofunctional therapy and craniofacial morphology like Dr. Belfort just showed.
Yeah.
Pues tenemos dos preguntas. ¿Qué es el problema y qué es la solución?
Dame el contexto, por favor.
En nuestra área de respiración, función y disfunción, ¿qué es el gran problema para el mundo y qué necesitamos hacer?
Primero que todo, necesitamos un importante trabajo entre las profesiones, entre los profesionales que nos dedicamos a las ciencias miofuncionales.
So she says that it's absolutely essential that there be very clear collaboration between the specialties. And that myofunctional therapy and myofunctional sciences is like a bridge to make that happen.
Vemos en nuestros pacientes dificultades no solo a nivel de la lengua, sino también a nivel de la postura, de la musculatura yoroidea y también de la posición craneocervical.
So she's coming from the perspective of being a doctorate student or graduate in PhD in speech pathology. They're looking at language, you know, from a fundamental perspective, but really this all drives posture and you cannot avoid the interrelationship.
Y también los experimentos realizados con animales nos llevan a pensar en que hay muchos cambios en la microestructura, a nivel de las fibras musculares y a nivel bioquímico de los sujetos que experimentan obstrucción nasal y también respiración por la boca.
So she wants to point out that animal models, such as with Dr. Takashi Ono, our keynote speaker, are absolutely critical because the intermittent hypoxia that creates the biochemical situations that creates things like micronathia, that creates things like the altered craniofacial morphology are essential to our understanding. So we really need to lead with these kinds of understandings of the impact of intermittent hypoxia.
Y siento que la solución está cada vez más próxima y es cada vez más grandiosa porque significa que tenemos que continuar estudiando, que tenemos que continuar observando a las distintas funciones de la motricidad orofacial en conjunto, porque respirar por la boca es un problema que implica afectaciones en las otras áreas, como en la deglución, y también nos lleva a un deterioro de la salud en general.
So really, we need to do more studies, but we know enough now with myofunctional therapy that it has an impact, not just on these questions on posture and breathing and swallowing and speech, but really on systemic health.
Por lo tanto, quiero agradecer una vez más a la AAMS por esta invitación, por su mirada observando a las ciencias miofuncionales de forma integral. Gracias para Samantha, para Rosalba y para todos los miembros de esta mesa y un abrazo muy grande para todos ustedes.
So she wants to thank Samantha and Rosalba and the AMS for its scientific leadership and collaboration in advancing myofunctional therapy around the world, and that this is really a critical function that we all need right now.
Thank you, Mark. Thank you, Mark, for translation.
I strongly encourage you to read her doctorate and to see her presentation, which we translated. Thank you very much.
Thank you very much.
We have some more panelists. I know that Mariana Evans has joined us. Rosalba, did you want to say something?
I wanted to say something that may be a little bit controversial, just about intermittent hypoxia. Do you know that the intermittent hypoxia, people always focusing on, you know, the negative effects of intermittent hypoxia, but there's some stuff too showing that intermittent hypoxia in the presence of normocapnia, you know, normal carbon dioxide levels, actually has a training effect on the airway. I just thought that was kind of an interesting little, you know, different point to make.
Very interesting.
Yeah.
Yeah. So I wanted to bring it over to Mariana Evans and introduce her and her work here. I want to thank you for being with us today. You've contributed enormously, and we're looking at breathing, function, and dysfunction, and looking at kind of from a bird's eye view, overview of what, from a medical point of view, in how we get this information out and what the challenge is and what the opportunity is from an event that we're exchanging information like we are with this community. So Mariana, would love to hear your perspective.
Sure. Thank you so much for inviting me to this panel. I think this is probably one of the most important topics in orofacial myofunctional therapy and also in sleep apnea today and in orthodontics too. And I think when you look at the literature, there is definitely sufficient evidence to support that abnormal breathing through your mouth is going to affect facial growth. A lot of this research was done in the 70s, in 60s, and it needs to be continued. It's not complete. And the problem is very complex because there are different pathways for this craniofacial myofunctional disorder. In some children, you may develop, the problem may start developing with abnormal breathing. In another child may start with bad posture. In another child may start with a tongue tie or already deficient skeletal structures from birth. So there is, the problem is so complex, so it's not very easy to study. But I think right now with increased awareness and increased impact that myofunctional therapy community has on educating orthodontists, educating ENTs, sleep physicians, the research that is evolving from this group, I think it's very critical. I, as an orthodontist, have to say that if I cannot correct the function, 90%, if not 100% of the orthodontic treatment that I do, it is not going to be effective. So we have to do as much as we can in terms of collaborating in research and developing some systems to screen and evaluate these children and adults with the disorder so we can understand it in a team approach. The other problem, the biggest problem that I see is actually, let's say that the orthodontist and all specialists that are involved in the treatment of the patient are on board, and the patient is on board, and the patient is going to go through the therapy. The problem is that if you go through the therapy, let's say you have like 10, 20 sessions of therapy, but what about 24/7 that the patient is doing? So I think the problem is significantly larger than we may think, and it has to start with the public education, with the public understanding that there has to be something different done from the moment that the woman gets pregnant, how she is going to carry the pregnancy to the moment that the child is born, what we can do different today about raising these children, because these problems start in a young age. And it's a problem of diet, it's a problem of poor air, poor breathing, and it's also a problem of posture. As soon as that baby can hold something in its hand, we give that child an iPad or a device for them to stop discovering the world around them. They are starting to discover the world on the device. So I think this group has a very important role to play, not only in terms of integrating its knowledge and the role with other disciplines, but also in terms of educating the public about the importance of the facial growth and how this dysfunction is affecting the facial growth and overall health of the patient.
Yes.
So thank you so much for everything that all of you are doing and for this beautiful meeting that you put together. We need more of this. Thank you.
Thank
for your
you.
attention.
Thank you very much. So we'd like to hear from Vic Veer, Dr. Vic Veer, who's an ENT.
Hi, everyone. Sorry, as I said to you, Rosalba, I've got a sort of, I don't know much about this stuff. You guys are going way over my head. I'm just a simple, rather stupid surgeon. But what I said in the chat, sort of what you said about the intermittent hypoxia causing some sort of strengthening of some of the muscles. I often see that when I do a drug-induced sleep endoscopy. I'm watching people apnea inside their airway, and then straight after the apnea, you see a sudden massive dilation of the airway. And it's not them waking up, because sometimes it happens even when they're under the effect of anesthesia. I tend not to do a typical anesthetic DICE. I normally wait for them for the anesthetic to wear off, so I could just wake them up at any time. But I see it almost every time when I do a drug-induced sleep endoscopy. I see people after an apnea having a massive dilation.
Yeah.
They get a spurt of air. And I've often thought, what is going on here? Because it's not, it seems like a very good response to an obstruction. But if we could harness that, that would be great. And it's obviously a breathing thing. But I need you guys to help me with that, because I can't fix that.
Well, do you know, there's a bunch of research about it. Somebody called Makita and some other researchers, but what they describe is how, the right dose of intermittent hypoxia actually causes strengthening of nerve pathways that improve breathing control and upper airway dilation. And so they describe it as being long-term facilitation. And so a lot of different breathing techniques can help those brain pathways of long-term facilitation and improved neural drive to the upper airway dilating muscles. So a lot of people know that, say, for example, in the Buteyko method, people use breath hold. You hold your breath and you think, why does holding your breath improve your airway? But it's just activating reflexes. It's not just about the raising of CO2. It's about the activating of these reflexes, they get lost. There's actually a therapy that's called intermittent hypoxia therapy, where people are given hypoxia within the dose that's their adaptive range. And they found that that does the opposite of what intermittent hypoxia from sleep apnea does. So it actually helps to lower blood pressure, you know, reduce stress, decrease inflammation, and improve breathing, and the drive to the upper airway muscles. It's crazy, but interesting and worth exploring, you know. What do you see the problems and solutions in this field from your perspective?
As I said, I'm a surgeon, so I just want to cut things out. From my point of view, what I don't seem to understand is when I watch people breathe, when they're snoring and having apneas, I can see them going, I can put them into different stages of sleep. And what I often see is in certain stages of sleep, I can see everything sort of slowly sort of slowing down. The way they're breathing becomes longer and more prolonged. And you can see with the different forms of breathing, the fast they breathe or the deeper breaths, you can see different changes in the airway. Sometimes I see, oh, look, if you're taking long, deep breaths, you see the tongue sucking in, you see the back wall, the lateral pharyngeal wall in sort of fast sort of breathing, particularly when the airway, if you're in this posture where your tongue is falling forward, you see the lateral pharyngeal wall collapsing in, like if this is your airway like this, it sort of collapses in like a V shape. And all this is sort of causing turbulence. And this is what, as an ENT person, we look at turbulence and we think of turbulence and fluid dynamics, but we don't, I'm no maths genius. I don't understand turbulence at all. Mm-hmm. And that's what we see causing the turbulence, causing vibrations across the palate. So I don't think the palate's ever a source of problems. It's sort of lower down. Seeing that sort of slow obstruction causing the turbulent air, which is causing the palate to vibrate, and it seems to occur on both ends. I don't understand it at all, because if you block your nose, as you were saying, I could do that in the middle of a test and just see what happens to the airway, and it's just crazy. This is why we need you guys to fix it. Just tell me what to do, and I'll sort it out.
Yeah. So what about ENT? You know, like in terms of multidisciplinary collaboration, which is something that has been mentioned by Mariana. Specifically, that how would people in this field, of orofacial myofunctional therapy improve their kind of, ability to work with ENT surgeons? Yeah,
I think as a specialty, we're very surgical, and we're not particularly open-minded, because we're all sort of alpha male type Asperger's spectrum type people, but I think we look at numbers really well, and with all the research you're doing, because you're doing good research now, and it makes sense to us because it translates to what we understand. A lot of the stuff's been said today, I'm lost. It doesn't fit in with what I learned at med school and what I learned through my training. But when you see numbers coming through, we can understand that, and we go, well, how is this working? It doesn't make sense. And that's when we get excited, because if I can avoid doing an operation or make the operation much easier for myself, well, then that's great. And now, I mean, for years now, I've been saying, I'll do this bit of the operation, but I think this bit you can sort out with, I think at the start I used to say singing. I knew a lady down in Bristol in England. I got her to start teaching all my patients how to sing, because that dealt with that side of the operation, so I don't have to put them through that bit at all. Yes. And we were doing research, and then suddenly myofunctional came into England with people who are here, and I'm trying to catch up with you guys, but what I'm finding is that I'm having to do less because you guys can help me out, and you guys are helping me out with some bits. And then I don't have to put people through horrible operations, because actually some of the operations are dreadful. Some of them are easy, and all you're doing is scarring and stiffening certain areas up to help them open up the airway. Like, for example, if you've got a big tonsil, shrinking that down just reduces the turbulence in the back of the throat.
Thank you so much. I want to make sure that we can have some others step in.
So sorry.
No, Dr. Vera, it's really great to hear from you, because it really helps our community know what we need to communicate better. And the data and numbers is really what operates how people work. And so that's a very clear pathway. And so it's an inspirational point, and as were many of your comments. I want to hear from Dr. Keith Thornton. We are here discussing these concepts and issues around breathing, function, and dysfunction. And if you're able to weigh in on this topic from your perspective, what you're seeing as the challenge and the opportunity.
Well, what I do specifically really is to treat roadkill. And my focus really is on adults and severe and not so severe sleep apnea. What I do is try to apply what I've known about both the anatomy and the chemical control of breathing to my devices, so that while somebody's asleep, they have normal physiologic breathing. So what I can do is show some slides, if that's appropriate at this point, to do what I do, or if it's in another time, that's fine.
You know, it'd probably be better because we're running out of time.
Okay.
But if you can highlight them and send them, we can always put them in later.
I'll do it, but let me explain just very quickly. Nobody is talking about closing the mouth off and nasal breathing with devices. They also don't talk about the volume of the oral cavity to accommodate the tongue. So what I've done is looked at some of my studies and other studies, and vertical is very important, what we call freeway space to allow room for the tongue and the oral cavity. We're looking at opening up the bite 13 to 14 millimeters, and these are all RCTs, and it's showing significant improvement. What I've really done is added what I call a mouth shield, and what we're doing with increase of CO2, we're starting to see that we're improving and treating AFib and central sleep apnea. But this goes back to Danny Eckert's work, and nobody really has looked at what I call physiologic breathing device, not only where you protrude the mandible, but you open it up to give room enough for the tongue. Tongue comes forward, and you put a mouth shield on it and make them breathe through their nose. And it significantly, all of my patients, which we've added that, or virtually all added the mouth shield, say we can move the jaw back, and it improves their breathing and their outcomes.
Well, I just wanted to comment. Thanks, Dr. Thornton. He's much too humble here, but you know, to introduce him a little bit, he is one of the real key leaders in the invention of a dental sleep appliance, a mandibular advancement device, a MyTap, the TAP. And, you know, he's made a concerted effort too to do science around mandibular advancement devices. And with conversations that we've had going back 8 years or 9 years or so, it's really exciting to see him always really keeping central tongue space and freeway space, like he just mentioned. So I just want to mention he's going to be a late-breaking addition to the program. So we're looking forward to a presentation coming in. So look for it in the sleep track.
Yeah. So I think we need to hear from Tom, don't we, in the brief time that we've got left.
All right, my assignment given to me about 8 o'clock this morning was to say, what is the problem and what are we going to do about it and what can we do to help people? I'm a Southerner, but I can talk fast. So I'm going to show some things I put together this morning. All right, these are the homeo blocks that Ted Belfour designed for me because I was dying from chronic inflammatory disease because I never could breathe. I was a mouth breather and was incredibly sick. And so you can see changes going on in my mouth wearing this appliance. And you can see what I look like when I was 68 on the left, what I look like once I got treated. And you can see me here getting 2 years older instead of 2 years younger, although it looks like it's the other way around. And you can see the facial development that went on and cured most of my lifetime chronic diseases. These films show in red, Ted did these for me, shows where I actually had osteogenesis at age 68 to age 70. Was able to actually grow these structures. You can see these structures can be labeled, and it also had osteogenesis and repaired my damaged left temporomandibular joint. If you look at James Nestor and you look at the results he had, he needed the right side of his face developed. I need the left side of my face developed. And you can see that this has happened by using these incredible useful appliances. Seeing that we could actually change myself at this age, we tried to apply this to other people. And we realized it's now possible to reverse these disease processes at any age. So what do we do about it? Well, we have to educate the patient. Before we do any mechanical intervention, we have to create an obsessive awareness of tongue posture, excessive awareness of their head and shoulder posture, and get them really thinking about when they're breathing through their mouth, and initially see if they can breathe through their nose by taping their mouth. We have to educate these patients because we have to make them want to heal themselves. Our goal is to do no harm. We want to follow the least aggressive path we can. Least aggressive. There are a lot of radical ways to treat these patients. So sometimes patients, if they're really sick with sleep apnea or we're afraid they're going to die tonight, we might want to put them on a CPAP or a TAP appliance to see if we can get them breathing right now. But our goal really today is to try to get them off of this and try for a cure. Well, what are the problems? One of the biggest problems is all these tethered oral tissues, because it all comes down to the tongue and the nose, obliteration of the airway. So we were all trained to look at the teeth first, but we really need to take, instead of just looking at the teeth, let's look at the neighborhood in which the teeth are growing. And if we actually take care in how we take our impressions and trim our casts, we can see an awful lot about compensations that are going on in the body with muscles, exostoses, all due to this restricted tongue. Gives us a much better view of what's actually going on. So we have a whole new way of looking at patients, looking at it from the lingual, looking at their eyes. And my go-to appliance right now, started with Ted and then with Scott Simonetti, is the pod appliance. Don't have nearly enough time to talk about it. But as he said, if it's in the mouth, it's going to take twice as much room to get the tongue up where we belong. Scott Simonetti has helped me tremendously with this. I think Scott's the smartest man in the room. Doesn't get the credit he needs. All right, if we look at how a mandibular advancement appliance works, we can see it opens the oropharyngeal airway, but it puts pressure on the maxilla. And it's an underdeveloped maxilla that's the problem that we started with. So if we wear it on the lower teeth only, this pod appliance, there are no restrictive forces on the maxilla, and it encourages and promotes maxillary development through mechanotransduction. Here you can see a CT scan that's made of the airway just by inserting the pod, and you can see that there's tremendous volumetric change just by lifting the tongue and opening like that. So that's the first thing we have to do, is to try to give them room that they can start to work on changing themselves. Paula Watkins worked with me for 46 years. She was trained by Joey Moeller, Sandra Colson, and Patrick McCown. She has done more to help our patients than I have, because it's the changing of behavior that may be the most important of anything. We're dealing with structure, function, and behavior. If we don't change the behavior, we're not going to get a cure. And we need the help with all of these other devices and substances to help train the patient to learn to breathe through their nose. It's very important that we have someone who can do our tongue releases. Here you can see as we're releasing the tongue of a good friend of mine, periodontist, who we developed with a homeoblock. He's done myofunctional breathing therapy before and after his release, because we must change this behavior. And it's possible to help reverse these disease processes through development of proper breathing, swallowing, and mastication. All three of them are tied together. If you have dysfunction in one, you've got dysfunction in all three. We can do this at any age. You can see the sickness in the patient's eyes. It's the windows to their souls. Here are eyes of patients before and after treatment. You can see the change before and after as these patients appear to be waking up. These are patients we're treating right now who are sick, All of them need myofunctional therapy. They all need tongue releases, and we're all hoping to work with a team to actually transform them. If we look at a 40-year-old patient, after he's worn a pod and taped his mouth for 3 months, you can see it looks like he's waking up. We can tell a great deal by looking at the eyes of these patients. And really the gold standard, we all kinds of metrics we can measure, but what we really want to know is how do you look and how do you feel? Here's a patient after 3 months wearing a pod and tape after a frenectomy. Can't really show that one. Does age matter? Here's an 81-year-old man. You can look at the change in this gentleman in 3 months. He had his tongue released, wore a pod, taped his mouth shut at night, and had myofunctional therapy with Paula. Here's a patient who had all of that, including homeblock therapy. He's got 16 fewer symptoms than when we started, and it looks like he's waking up from the dead. Here's a patient who was literally dying, and after treatment, myofunctional therapy, pod, tongue release, Buteco breathing, and working with the chiropractor. Let's talk about the posture. Look at the change in his posture. This patient had an AHI of 81. He now has an AHI of 1. He was hypertense. He's no longer hypertense. He was diabetic, and he is no longer diabetic. And he's gone off of 8 different medications. So this just kind of shows that at any age, this is a poster I made for the Restorative Academy that basically says we need to look at faces. We can help these young people before they get the end stage of obstructive sleep apnea. The first thing every dentist should do for every patient is to make sure they can breathe. Our primary duty to them is to make sure they can breathe. The teeth are of only secondary importance, and we want to create these goals for them where they move out of the allostasis from disordered breathing into a walk to wellness through functional diaphragmatic breathing. That's all I got.
It's great. That's quite a show, Tom Colquitt. I knew you had it in you. I heard all about it. So, wow. Well, I want to say thank you for that because, you know, when we see this in real time with visuals and images and stories and lives, that's what touches us all. We are here today talking about breathing and function dysfunction, how this impacts so many systems and the craniofacial, morphologic, respiratory complex. It's all embedded in one body. And because our panel has been so, we're a little bit over time, so we're going to stay on this live feed today. I just want to let everyone know. Rosalba, you can say some final words, and we're going to stay here, transition to the next panel. But Rosalba, please, I'd love you to wrap it up.
Okay, so you know, we still heard a lot about structure, and I think we didn't hear enough about function. So I still think we got to go there. I mean, you know, it's fantastic to see those changes. It's really amazing, and it's really sort of wonderful, you know, that people are progressing forward with new devices and new ways of expanding, you know, the growth of the face and all of that sort of stuff. And that's super, super important, and grateful to watch those presentations and see the, you know, actual real life changes. But I still say we've got to focus more on function with breathing, because it's a huge field that could add a lot to this field that's not explored or developed sufficiently. And there's more to breathing than Buteco. There are many, many breathing therapies, lots of approaches to strengthening and improving respiratory function and functionality, the resilience, the efficiency of the breathing system, which impacts on, you know, all the muscles of the upper airway and the brain and all the neurological issues that are behind and associated with, you know, these airway breathing problems. We need more research. We really need more research. It's just at the very beginning baby stages, but I think that there'll be, you know, good things come out of that. So thank you very much, everybody. And thank you, Samantha. And thank you, Mark.
Well, it's been a pleasure. And if you're out there watching right now, I'm going to put a screensaver on as we transition into the next panel. So everyone here, you'll come on in about 3 minutes. We're going to have track 5, frenulum inspection, surgery, and rehabilitation across the lifespan. So just give us a minute, and we'll be back in about 2 minutes.